An important part আমি যেটা বলছি, for every case, for particularly long cases that you have 4-5 investigations যেগুলো the teacher is after present the case, they will obviously ask you questions from your case. Okay, so they will go for investigations. Always start with the most basic investigations. I have always explained this in details. Don't start with CT scan or MRI scan. Okay, always start with basic examinations. I have explained this in details multiple times. Investigations we do for two main purposes. One is a confirmation of the diagnosis, and second is to proceed with the treatment. Right. So first part is confirmation of the diagnosis. For example, you have a deviated nasal septum. Okay. You have examined the patient. You have seen a deviated nasal septum. Okay. It's already clinically seen. So what extra examination you need to do? The DNS patient. A patient has come with a long case to the DNS patient has come with a clinically you have diagnosed as DNS. So the examiner is asking you what investigations would you do. So always think in your mind that we will do investigations in two basic broad divisions: to confirm our diagnosis and to proceed with our treatment. To confirm our diagnosis, I need to see the disease in details further because I have only seen with the anterior rhinoscopy. OPD আমরা কি করেছি? We have just done an anterior rhinoscopy. We have used the speculum and saw a deviated nasal septum. We don't know where the septum has gone inside, whether the coana is open or not. For example, I have planned a patient for a septoplasty, and while doing surgery, I find out that the patient has a coronal trachea on that side. We need to know what it is. So I need to go ahead with a diagnostic nasal endoscopy and an X-ray of the PNS to rule out any associated sinusitis. The DNS. So nowadays we don't do X-rays much, but for your exam you'll have to say, okay, we have to do a nasal endoscopy to see and one X-ray, PNS or MBU. Okay, so these two you have to mention. Then they will ask you, okay, now the patient, if the patient has complications, for example, if the patient has a orbital cellulitis or any telltale signs of sinusitis like gross sinus tenderness, gross nasal discharge, purulent discharge, vehicle discharge, then your plan will change. Obviously, you will not go for an X-ray. Then you will directly go for a CT scan. So a disease without any complication, start with basic examinations, basic investigations. A disease with complications, go with advanced investigations because you don't want to waste time on that, doing an X-ray which will not help you. Okay, so most of your cases will not have complications. Obviously, we'll give cases without complications, mostly with simple straightforward cases, but there have been times when the examiner will ask you, okay, so your case is this, so let's say the patient has this, then what will you do? Okay, the examiner will say, okay, let's say that along with the DNS that you have found out, the patient is also complaining of pain over the left maxillary region for last few days and tenderness. So what is your clinical diagnosis? So you will say probably it's a case of left maxillary sinusitis associated with the deviated nasal septum. So the examiner will ask you, okay, what all investigations you're gonna do? Then you say, okay, we will plan for an evaluation of the middle meatus. So we'll do a nasal endoscopy, and since the patient has a complication associated with the deviated septum, I'll preferably go for a CT scan of the paranasal sinuses. Okay, so the examiner may ask you what else, other investigations you can do. So okay, so why, when we do MRI and when we do CT scan and when we do a contrast CT scan, what is the idea of a CT scan? Yeah, they should go CT scan. But MRI to jante ami what I want you to understand is what is when we do order a CT scan, when we order a CT scan with contrast, and when do we order a MRI? Soft tissue. So MRI has a better soft tissue delineation. So if we are expecting something which is little soft tissues more, and we do not want much of bony details, then we preferably go for a MRI. we have to do one investigation. If we are concerned with the bony structures more, okay, we go for a CT scan. Okay. Then you will ask me, sir, then why don't we do an X-ray? The problem is X-ray has a lot of overlap. Whenever we are doing an X-ray, there is a lot of overlap, and the delineation is also not as clear as a CT scan. So CT scan is a modified X-ray only, right? It's just a modified X-ray. So just taken in different planes so that we can create an image out of it. Another thing is when we do a CT scan with contrast. So when we do a contrast, what is the idea of contrast? Someone? Contrast আমরা কোথায় ইনজেক্ট করি? ভেন্সে, তার মানে ব্লাডে। Then vascularity. To assess the vascularity of the lesion, we do a contrast enhanced scan. Whether it is a CE MRI, most na samne boshe, or a CE CT scan. Okay. CE CT scan. Okay. The purpose of a contrast and giving IV contrast is to assess the vascularity. Right? So we are suspecting a vascular tumor in the nose. So for clinical, see for example, a patient has come with a nasal polyp. Okay, I have seen a nasal polyp. The polyps are not so vascular structures because these are polypoidal mucosa only, which are fluid filled edematous polypoidal mucosa, right? Edematous swollen mucosa. So they have more fluids than blood. So we do not need a contrast CT scan for evaluation of nasal polyps. We do a non-contrast CT scan. But if the patient has come with a vascular tumor, say an angiofibroma, okay, then we need to do a CECD, or the patient has come with epistaxis. We are suspecting a nasal mass, a sinonasal mass. Okay, then we will need to do a contrast enhanced CT scan. So vascularity, anything related with blood vessels, go for a contrast enhanced scan. Anything that you are more than aware is unlikely to be related to vascularity of the lesion, or we don't need the vascularity of the lesion to evaluate. Just case scenarios gulo korai, case scenarios gulo korachi. Not as red as the surrounding structures. Okay, see this structure is much more whitish and pale compared to the adjoining mucosa. So it's unlikely to be very vascular. বুঝতে পারছিস? See the color. The color is whitish and it's pale in color. So it's unlikely to be very vascular. That is the definition of a polyp. Okay. So you see, when you see the CT scan, you see there is a homogeneous opacity. See, this is an opacity that you can compare with the other side. You can see the maxillary sinus, right? You can understand what is the maxillary sinus, right? বুঝতে পারছিস না? Everyone knows maxillary sinus, right? So this is the maxillary sinus which is completely opacified on this side, along with opacification of the nasal cavity, ethmoid sinuses. Okay. So this what kind of section is this? Coronal section. And this is it's called an axial section. Axial cut. ठीक है? Sagittal এরকম ভাবে কাটবে, axial এরকম ভাবে কাটবে, parallel to the horizontal plane is axial. Okay, so if when you see the axial scan, you see there is opacification of the maxillary sinus with disease in the middle meatus, posteriorly going there and obstructing the completely opacified. But see, the important part is all of this soft tissue opacity is homogeneous. So it is like almost the same color throughout. There's not much of contrast, changes. যতটা দেখছিস জিনিসটা পুরোটা দেখ অলমোস্ট সেম কালার, কোনো ইরেগুলারিটি ইনহোমোজেনিটি নেই, অলমোস্ট হোমোজেনাস. So that means this is most likely a regular polypoidal tissue because it has a similar consistency and fluid throughout. If it was a fungal sinusitis or something like that, there would have been heterogeneous opacities because of fungal debris in structures. Okay, so that is a key difference. They may ask you what in a fungal sinusitis, what kind of picture will you get? The first answer is the opacity will be heterogeneous, and there may be associated bone erosions, because invasive fungal sinusitis can cause bone erosions. Okay, and the symptoms may also be different, and the nature and characteristic of nasal discharge will be probably different. ठीक है, the fungal sinusitis you will expect a foul smell, a long standing disease, pain may be associated. Usually sinusitis you will never have. This is a polyp. It's not a fungal sinusitis, it's a clear cut polyp, and it is coming from the antrum and going posteriorly. So what kind of polyp is this?
Antrochoanal Polyp.
Yes, very good. So antrum, so this is the middle meatus, you can identify, right? This is the middle turbinate. So middle terminator laterally যদি আমরা যাই তাহলে তোরা বুঝতে পারছিস না, you are not able to understand the picture. Can you comprehend this? একটা খাতা পেন দে চট করে চলে দে। সো এটা তো তোর নাক, this is the midline. Middle turbinate এরকম আছে, এটা inferior turbinate, superior turbinate is like this. Okay, so here we have this is the middle meatus and we have the maxillary antrum here. এবার এই পিকচারটাতে কোন এরিয়াটা দেখাচ্ছে? এই এরিয়াটা দেখাচ্ছে। We are seeing the part of the middle turbinate here, and we are seeing the uncinate process here, that is this area, and in between here is the whitish opacity. So we are seeing the whitish opacity in the middle meatus. It's clear. So we are seeing the whitish opacity in the middle here, but this is a homogeneous, and it is according to this scans, you see, it is coming from the antrum and coming to the and going towards the choana posteriorly. Okay, this is the classical. See, you can see it's coming from the antrum, this tail, and going towards the choana. So this is a classical case of antrochoanal polyp. Okay, this first say it's a case of a nasal polyposis, possibly an antrochoanal polyp. And they may ask you what other types of polyps can be there. So there can be ethmoidal polyps, but what is the difference between antrochoanal polyp and ethmoidal polyp? They will have to pour, they will ask, they will surely ask. It's a very, very common question. Antrochoanal polyps are mostly unilateral, age is different. Ethmoidal polyps are bilateral most commonly. They are allergic polyps, antrochoanal polyps are not allergic polyps. Okay, treatment is different. Ethmoidal polyp can be sometimes very well treated with intranasal corticosteroids, and all. Antrochoanal polyps it will not work. We have to go for surgery and remove the polyp with the stalk. Okay, তো এগুলো একটু পড়তে হবে, একটু থিওরি পড়, না তো এগুলো কিন্তু পরীক্ষায় ফালতু পাস হবে। Need to read through this. ঠিক আছে, তাহলে antrochoanal polyp আমাদের কোয়েশ্চেন কি আসবে, তুমি আর কি ইনভেস্টিগেশন করবে? অবভিয়াসলি we have done a nasal endoscopy here. আমি দেখতে পাচ্ছি সিটি স্ক্যান আমি করেছি, it does not, there is a homogeneous opacity, no bone erosion. দেখ কোনো bone erosion হয়েছে কি? All the bony things are intact. Is there any bone erosion you can see? No. So there is no gross bone erosion. Okay, so there is widening of this maxillary sinus ostium. এটা হচ্ছে ostium sinus এর এদিকে দেখ কতটা সরু আছে, এদিকেও কিন্তু কিছুটা polypoidal tissue রয়েছে, because if you see this scan you will see there is a polypoidal tissue over here also. ঠিক আছে, একটু একটু polypoidal tissue এই সাইডেও রয়েছে, but mostly it is this side. তো এখানে দেখলে বুঝতে পারবি, if you see closely here you see the sinus wall is completely bony, this uncinate process and everything over there, but here you see this is widened so much, because so the polyp has come out of it, it has widened the natural ostium. It always comes out through the natural ostium. In ostium যেটা থাকে, which is, what is the area called? Anatomy টা কি? Osteomeatal complex. So what does that? That is right, মানে osteomeatal, it's a 3-dimensional structure. Middle meatus কিরকম দেখতে হয়? Middle meatus না looks like this, say, নাকের মধ্যে। ঠিক আছে, so you come from anteriorly. Okay, vertical part অত জানতে হবে না, vertical part, horizontal part, so there are multiple parts of it. কেন বোঝাচ্ছি? See, when you see from anteriorly it looks like, so what you are seeing this part, এই যে এখানে যে ছবিটা দিয়েছে, so this hanging part, you are seeing the anterior wall. If you trace it, it curves like this. Okay, গিয়ে maxillar posterior wall এর সঙ্গে attached হচ্ছে। বুঝতে পেরেছি? So it curves like this. So this is called this curved area is called the basal lamella. আমি কেন বলছি বোঝাবার জন্য, see so this is a 3-dimensional space. বুঝতে পেরেছিস? মানে তুই সামনে থেকে যখন দেখছিস মিডল টার্মিনেটের মাথাটা দেখছিস, সামনেটুকু দেখতে পাচ্ছিস, you are seeing the middle terminate. If you go through this place you will get the maxillary sinus here, and the maxillary sinus drains like this outside. সেই জন্য পলিপ যেটা আসছে it is coming out from the maxillary sinus and coming along like this outside. এখানে নেবে because of the nasal air flow, since we breathe in it tends to go posteriorly. সেই জন্য অ্যান্ট্রাম থেকে বেরিয়ে মিডল টার্মিনেটের গা দিয়ে এসে নিচে আসে, তারপর আমরা বারবার যেহেতু নিঃশ্বাস নিচ্ছি we are breathing in forcefully, because breathing out is a passive process, we are not putting any force in it, but breathing in is an active process. Okay, we put more energy in it, so the power of the air going in is much more, or the force of the air going in is much more than the one that is coming out. Okay, that's why it pushes the polyp backwards and it goes towards the wall. And sometimes even on examination of the oral cavity, if you depress the tongue you can see the polyp hanging in the oropharynx. ঠিক আছে? তো এটা ট্রিটমেন্ট কি অ্যান্ট্রোকোনাল পলিপের? সার্জারি, ফাংশনাল এন্ডোস্কোপিক সাইনাস সার্জারি। স্টেপস ইউজুয়ালি জিজ্ঞেস করবে না, ভেরি আনলাইকলি, বাট বেসিক স্টেপস জিজ্ঞেস করতে পারে। হ্যাঁ, স্ট্রাকচারস গুলো আইডেন্টিফাই করতে বলতে পারে। এখানকার স্ট্রাকচার তো এখানে তো লেখাই আছে মোটামুটি স্ট্রাকচার, বাট এটাই থাকবে এরকম ব্যাপার না। সো মিডল টার্মিনেট, মিডল মেটাস, আনসিনেট প্রসেস কাকে বলে এগুলো একটু জানিয়ে যদি পড়তে চাস I can take a class properly on the anatomy of, because it's very confusing. Undergraduate I was also very Osteomeatal Complex anatomy টা তাহলে একদিন we'll discuss SGD তে, because it's very মানে তোরা এগুলো ঠিক করে I don't know, I've not gone through this in detail, that's why you don't feel interesting, but these are actually very interesting. If you have the 3D picture it becomes very easy to understand, and পরীক্ষা questions will not miss. বুঝতে অসুবিধা হয় আন্ডারগ্রেডে আমার I had real trouble, আমি বুঝিনি। Post graduation when we started doing procedures, endoscopies regularly, then the picture came. Okay, তো এটা যদি ভালো করে বুঝতে পারি it becomes very easy and it's actually very nice, it's not very complicated, just এই টার্মস গুলো যদি একটু জানতে হবে, that's it. ঠিক আছে, নেক্সট ডেফিনেটলি পড়ি দেবো। বলিস কবে পড়তে চাস, just let me know. I want interested people only. I want interested, আমার 11 ছেলে দরকার নেই, I want interested people who will come and try to learn. That's it. Yeah. And what is this? This is a tracheostomy. So what are the indications of tracheostomy? Oh, what is tracheostomy first? To tracheostomy বলছিস, তো কি কথা আরে চলে যাচ্ছে? Maintain. No, first you have to open up, no? So say it's an surgical process to create an opening in the trachea and connect it to the skin. So it's an ostomy, not an otomy. So in a tracheotomy you just make an opening. Tracheostomy means you are connecting it with some cavity on the exterior. You're connecting it with something else, that's an ostomy. ঠিক আছে? Then gastrojejunostomy, cholecystoduodenostomy. So there's an ostomy, connecting something with something. So tracheostomy means you're connecting the tracheal lumen to the skin outside, exterior. For maintenance of the passage, you're putting the tube in. The whole purpose of putting that tube in is to maintain the passage. Otherwise, there will be collapse of the tissue. It will be blocked. Right? So, what is the indication of doing a tracheostomy? যে কোনো trauma respiratory distress এ tracheostomy করবো? So, see, I think বার চেষ্টা কর. Why are we doing it on the trachea? If you think like this, you will never forget. আমরা opening করছি trachea তে. We are creating opening the trachea. So any obstruction above the level of trachea, we are bypassing it. পেশেন্ট এখান থেকে নিঃশ্বাস নিচ্ছে, উপরে মুখে নাকে গালে কি হলো ডাজন্ট ম্যাটার। So any disease above the trachea,
large thyroid swelling with compresses.
where is the level of thyroid? Sometimes we do, you're not wrong, but don't say this, you'll be in trouble. Start with diseases of oropharynx, larynx, hypopharynx. So any orohypopharyngeal mass or anything that is causing an upper airway obstruction. What do you mean by upper airway? Above the level of glottis. Okay. So anything above the level of, means from the larynx and above, if there is an obstruction, then we can do a tracheostomy to bypass it. Okay. That is an indication. Another very important indication is prolonged intubation. Why? Because if you keep the tube for a very long time, it can go to, no, not aspiration, there can be stenosis and tracheomalacia. Okay, aspiration তো তুই কাফ দিয়ে রেখেছিস, বাট এদের এখানে মিনিং এর রোল আছে, there অনেক কিছু আছে. So tracheostomy is a short note also. Read in details. Tracheostomy may come as a short note. It's very common. Tracheostomy short note. কারণ বাইভাতে তো অনেক প্রশ্ন করে tracheostomy থেকে. Okay, the types of tracheostomy. I think I have discussed this in your class in details. High tracheostomy, mid tracheostomy, low tracheostomy, elective and emergency tracheostomy. There are many ways to classify tracheostomy. So we can, around the timing of the procedure, it can be an emergency tracheostomy. Okay, so the examiner will ask you, okay, so you are saying that it's an upper airway obstruction, then you will do a tracheostomy. So how will you understand an upper airway obstruction? The patient তোর কাছে এসছে, he will say ki tracheostomy লাগবে না. What? Stridor. So stridor is a telltale sign of an upper airway obstruction. Okay. So what is the definition of stridor?
Sir, glottis এর উপরে supraglottis
আমি তো পরীক্ষা নিতে বলেছি, স্যার গ্লটিসের উপরে বললে তো হবে না, 10 এ 2 দেবে. Stridor is noisy breathing. Okay. Ever there can be inspiratory stridor, there can be biphasic stridor or expiratory sound. Expiratory sound is wheeze. So inspiratory,
glottis এর উপর, আর একটা glottis biphasic, আর glottis এর নিচে subglottis হচ্ছে expiratory.
subglottis is biphasic. Up to the level of glottis, it is inspiratory stridor. Expiratory sounds are lower airway sounds, which are mostly wheeze. ঠিক আছে? So till the level of glottis, it is upper airway obstruction. That will cause an inspiratory stridor. So inspiratory stridor is a telltale sign of upper airway obstruction, where we have to go for a tracheostomy. ঠিক আছে? Biphasic stridor is usually at the level of subglottis. Once it is inside the trachea, it is usually an expiratory sound. ঠিক আছে? So আমরা সাবগ্লটিসের তলায় ট্রেকিওস্টমি করছি, তাই জন্য ইন্সপিরেটরি আর বাইফেসিক দুটো স্ট্রাইডারের ক্ষেত্রে we can go ahead with a tracheostomy. You are never wrong if you are doing it. Okay, what is the timing of tracheostomy? Many surgeons ask this bad question. When would you think it is right to perform a tracheostomy? Okay, so that depends on, clearly say that depends on the severity of the problem. At that point of time, the distress of the patient, his vitals. Whenever the surgeon thinks that it's the best time to perform the procedure, we go ahead. So there is no clear cut any guideline that you will have to do tracheostomy, emergency tracheostomy. For example, elective tracheostomy, prolonged intubation more than 8 to 10 days, it's better to go for tracheostomy. Some books say 12 days, some books say 14 days, but 10 days is standard. You are never wrong if you say more than 10 days. Okay, prolonged intubation, you can go ahead with the tracheostomy. Achha. High tracheostomy, what is high tracheostomy, what is mid tracheostomy, what is low tracheostomy? Here comes your answer of about thyroid. So thyroid isthmus is at the level of second, third tracheal ring. So if say there is a thyroid mass or a tumor, that means it has come down further. Is it easy to do a tracheostomy? No. Because below the cricoid, you only get 2 to 3 rings in the neck. Maximum 4 rings in the neck. So if there is an enlarged thyroid mass, which is obstructing that area, okay. So thyroid mass causing stridor must be pretty big enough. Because it is infiltrating the trachea and or compressing the trachea enough. So it has to be large enough. বুঝতে পেরেছি একটা থাইরয়েড মাস ও ছোট্ট একটা থাইরয়েড মাস তো আর ট্র্যাকিয়াল অবস্ট্রাকশন করবে না একটা বড় মাস হতে হবে so that it has significant pressure on the trachea. So this kind of mass usually has rectosternal extension. You will not get space to find the trachea here in the neck. In those cases we sometimes have to do a sternotomy and do a mediastinal tracheostomy. It is usually done by a thoracic surgeon along with an ENT surgeon. So they do the sternotomy for us and we perform the tracheostomy. But it's extremely rare, it's not commonly done except in very critical scenarios. Okay? Okay? So tracheostomy ebar hocche what kind of tubes do you use? Tracheostomy tube you have seen? Have you ever seen a tracheostomy tube? What tube have you seen? Huh? Metal naam ki? It's called a Fuller's bivalve metallic tracheostomy tube. খুব commonly দেওয়া হয় এবং a lot of questions are asked. What is the purpose of these two tubes? যেগুলো ইনস্ট্রুমেন্টের ক্লাস যেদিন পড়াবো we will discuss. যদি আরো তো ইনস্ট্রুমেন্টের ক্লাস লাগবে আমার মনে হয় you are not prepared enough till now. If you see once you will never forget. So you don't see na, that's why you forget. This happens in luggage. হ্যাঁ সেগুলো তোমাদের see that is your responsibility, no one will call you. We used to go to the wards at 12 in the night, 1 in the night just to see some procedures that we have seen 100 times later on. তখন ওটাই একদিনের বিশাল স্পেশাল ছিল, পরে নিজেরাই 100 করেছি 100-200 করেছি, কিন্তু তখন for that time when you are fourth year final year students like you, I mean going to an appendix OT was such a big deal. মানে খুব ভালো লাগে যায় appendix OT দেখেছি, পরে হাউস স্টাফ শিপে আমি বোধহয় 150-200 appendix করেছি, but it was nothing, what was a very করে দে এরকম ব্যাপার ছিল, ঠিক আছে। কিন্তু but for that period of time, for you now seeing one case is also important because once you get the image you will not forget. So মাথায় রাখবে কোথায় হচ্ছে না করছে খোঁজ নিয়ে রাখ, go ahead see. Once you don't see you will not be able to understand. Surgical procedures are something that needs to be seen repeatedly, then only you master. And see, once you see you will not forget the small things, you will be able to answer clearly পরীক্ষা অনেক ইজি হয়ে যায়, অনেক তো পড়তেও হবে না এতবার, তুই আর প্রসিডিউরটা একবার দেখবি না তোকে এতবার পড়তেও হবে। আচ্ছা আর কি tracheostomy indications বললাম, complications of tracheostomy is a very common question. Okay, so in tracheostomy what we do, we basically put an incision. Where is incision made? So this is the cricoid cartilage. How we identify the cricoid cartilage? The first swelling, they come from above below, the first hard swelling here, that is the hyoid. Then we have the Adam's apple, right? That's the thyroid cartilage. Below that we have another swelling. So this is the cricoid cartilage. This is the cricoid cartilage, is a suprasternal notch. Midway between the cricoid cartilage and the suprasternal notch, we put the horizontal incision for a tracheostomy. That is a standard procedure. Sometimes if there is say a huge thyroid swelling coming up, we may have to go a little lower down, but this is the best site. So neck should be extended, okay, and this is the incision position. Then we cut the skin. Next what comes, the subcutaneous tissue, we cut it along the same plane and then we get the কি আছে তলায়, স্কিনের তো সাবকিউটেনিয়াস তলায় এখানে কি আছে, মাসেল, কি মাসেল, strap muscles. So what is the first strap muscle? Sternohyoid. Very good. Sternohyoid. First what we do, we cut the muscle, we split it, we split the muscles, okay, and there is the assistant is also holding a retractor, so we open the muscle up. Then what is the next? Sternothyroid. So then the sternothyroid we get, and again we split it. Some books say you can cut the sternothyroid, but we preferably do not cut nowadays. And then what we get? Homohyad. Homohyad is there. Thyroid কি করে পাবি তুই? Thyroid তো ওপরে. Thyroid. Strap muscle you will get only two. এই দুটোই পাবি. Then you will what will you get? What? You get the isthmus of the thyroid gland. তাই তো? Below the strap muscles we get the thyroid gland, right? তো thyroid surgery দেখেছিস? Okay. Well, what I'll do is I don't know whether we'll be able to do a case right now.
Yes, আছে দুটো দিনটা ছিল অপারেশন হবে না
অনেক কিছুই লেখা আছে. So what I will do is I'll try to take one proper SGT, 2 hours of proper class. Okay, we'll show some videos, surgical videos done by us only. ধর আমারই করা কিছু ভিডিও বা অন্য কিছু করা, তাদের স্টেপ বাই স্টেপ you will have a clear idea. Tracheostomy আর এই পার্টিকুলারলি তোর এই থাইরয়েডেক্টমি এগুলো দেখলে অনেক ক্লিয়ার হবে, and you will get interest also. ঠিক আছে, বারবার এটা বলি. আচ্ছা, complications, and then we get the isthmus of the thyroid. So what we do nowadays, we lift the isthmus. We don't divide it. আগেকার দিনে বলতো ডিভাইড করে দিত, আমরা we also sometimes have done it, like very rarely খুব ব্রড বড় isthmus থাকে তখন, but we prefer avoid doing division because it can cause unnecessary bleeding, unnecessary. Why will you divide? We just lift it with a double hook. Okay, a blunt hook. We hold the isthmus, we identify the lower border of the isthmus, we hold the isthmus and lift it up, and we expose the trachea along with the pre-tracheal fascia. And the very important step is to divide the and cut the pre-tracheal fascia, because if you don't do it, you will, কি শুনতে পাচ্ছি না? Bery's ligament thyroid এর সঙ্গে attached. Bery's ligament is something else. Problem is you will have a surgical emphysema because there will be air leaking in below the pretracheal fascia, because pretracheal fascia, so it is continuous with the other neck spaces, right? So it's a deep cervical fascia, it's a layer of the deep cervical fascia. So when the water, if it starts going in, it will cause a surgical emphysema around. So we divide and remove the pretracheal fascia wide enough, and then we open up the trachea. Okay, so we can take different types of flaps and curves are there. কেউ স্প্লিট করে এটাকে ওয়াইড ওপেন করে টিউবটা দিয়ে দেয়. So some people make a hole like this, just এই কাটলেজটাকে এখানে একটা ইনসিশন দিয়ে এখান থেকে কেটে এটাকে ওর থেকে কেটে they remove the piece of the cartilage and put the tube in. What I do personally is like this. I take a inferiorly based flap, open the flap up, suture it with the skin here, so that when you change the tube, you don't have a false passage because this flap blocks it. And later on, if I have to decannulate, I can just remove the sutures, it goes back in place. It clearly goes back in place very smoothly. So it's different ways of thinking. Eta niye kono details nei. So we open up the trachea, we dilate it, and we put the tube in. Okay? So we always use a cuffed tracheostomy tube while doing a tracheostomy. Why? Cuffed will prevent aspiration, because after a surgery there is chances of hemorrhage, and there is some chance of bleeding, right, from the surgical site. Even if it is minor, it can cause an aspiration. To prevent aspiration, we use a cuff tube, or you may need to ventilate the patient for some reason.